in a sec.
There you are.
Hello and welcome. Welcome to this Bone Matters series. We're just going to wait a second to allow people to join us, and then we'll get going. So, hello and welcome again to this Bone Matters series. This Facebook Live is all about scans and tests that are used for osteoporosis, and we're going to be focusing on DEXA, bone density scanning, which we know is one of the main investigations used for understanding our bone strength. And I know it's a subject close to many of your hearts. We've received lots of questions already, so just keep them going. I'm really pleased today to be here to talk with Jill Griffin. Welcome, Jill. Jill works at the ROS, but she is also a consultant radiographer, and so an expert in this field. I'm really pleased she's here with us, and I'm going to be asking her some questions so that we can all understand more about DEXA, what it offers, and to answer your questions. So let's get going. First question for you, Jill. Some people here might not actually know anything at all about DEXA bone density scanning, so can you just tell us what is a DEXA scan?
Absolutely, thank you, Sarah. So a DEXA bone density scan, DEXA stands for dual energy X-ray absorptiometry. So what it is, it's a scanner that uses X-rays to measure the amount of bone mineral in our bones. And it does that by counting X-rays into the body, counting X-rays coming out of the body. And when we calculate the difference in that number, we can work out the density, so we can measure somebody's bone density.
Great, so that really sort of sets the scene, I think. And just to remind us, what is DEXA used for? It's used in the field of osteoporosis, but what is it mainly used for?
So we use DEXA in 2 or 3 different ways. The first one is to diagnose osteoporosis. So the World Health Organization in 1994 gave us an indication that osteoporosis can be diagnosed with a DEXA when it reached a certain level. So we use that, according to the World Health Organization, to diagnose osteoporosis. We also use DEXA bone density measurements to inform fracture risk assessment. So there's some fracture risk assessment tool that helps us understand what somebody's risk of going on to have a broken bone or a fracture is. And the DEXA bone density measurement informs that and supports that and improves that prediction of fracture risk. And we also use DEXA scans, or the measurements from a DEXA scan, to monitor changes in bone mass. So we might scan somebody when they first diagnosed, and we might scan them 3 or 4 or 5 years later to see what has changed. So we do that for 2 reasons. One, to monitor bone loss in people so that we can start treatment at the right time, and also to monitor people on treatment to see if it's doing its job.
So lots of different ways we're using it, but as you've importantly explained, sort of often part of a sort of general bone health assessment to understand how strong people's bones are. And I guess there are going to be people perhaps wanting to know, do they need a bone density scan? And we're not really going to be covering that in much detail here. So, do have a look at our website for more information, and perhaps ring our helpline if you want to talk about that. But I think you've really helped us understand that it's really important for understanding bone strength. Can you just perhaps tell us a bit about what happens when you have a bone density scan? What can people expect if they're going for one?
Sure. So when you go for a bone density scan, you will probably be greeted by a receptionist, and they will check you in and let the radiographer or the scan technician know that you're there and ready. They may well have sent you a questionnaire about your bone health, which you can bring with you, and they may well ask for your medication so they can understand what medication you're on and how you're taking it. So the radiographer will collect you from the waiting room and will ask you some questions to make sure they got the right person for the scan. So they'll ask you to identify yourself with your name, your date of birth, and your address. And then in the scan room, then they may ask you to change into a gown, but depending on the kind of clothes you've worn, so you can actually help yourself here really well by avoiding any metal fastenings. So no belts, no buckles, no zips, and that can really help you in the scan room, so you don't have to get changed. But we want to make sure there isn't any metal work or any metal things overlying the areas of the scan, because we want to measure bone and not metal. So the scanner itself, it's not a tunnel. It's like a bed, and over the bed on a kind of arm like this is the scan detector, and underneath the bed is the X-ray tube, and you lie in the middle here. But this scanning arm is narrow, so it never encloses you. It might come up over your head and then back down to the scan area, but the radiographer stays in the room with you all the time, so that's really nice. We'll also probably ask you to raise your legs up onto a block, and that helps us get a really good measurement in your spine. We may also ask you to turn your feet in and use some positioning aids with some little Velcro straps just to help you keep your feet in, and that's so that we can see the whole of the hip joint and make a measurement to the whole of the hip joint. The whole thing probably takes about 10 or 15 minutes.
And it's not painful, you don't feel anything, do you, Jill?
You don't feel anything at all. No, okay. It's just like a normal, any other X-ray test where you don't feel the X-rays, you can't see the X-rays, there's nothing to feel or see at all.
Okay, that's great. And a common question people get asked is it the same kind of radiation level as when you have a normal plain X-ray, as they're called?
Okay, so DEXA is actually a really, really low radiation technique. So it's probably similar to a chest X-ray, maybe a little bit less than a chest X-ray, which in terms of the type of radiation we get walking around just by living on planet Earth is about 2 or 3 days worth of that background radiation. So we get background radiation from the geology, the rocks that make up our bedrock, from the gases that are in there, from cosmic rays, and some of it's environmental. So we all get exposed to radiation all day, every day. So it's about 2 or 3 days worth of that radiation.
That's very helpful. So not to worry too much, because sometimes people are concerned about having repeat scans.
Well, what's really nice is because it is so low dose, the radiographer stays in the room with you all the time. So us radiographers working in the field, we just rarely pick up a dose at all occupationally. So we can stay in there. It's really that low.
Lovely. So let's get on to a bit more about what your bone density scan means, because I know we get lots of questions about this. You've talked about diagnosing osteoporosis, but people ask a lot about all these T-scores and Z-scores, and what exactly is it telling them? So perhaps you could just begin to explain that a bit.
Sure. So the World Health Organization I mentioned earlier set this benchmark as osteoporosis is diagnosed when your T-score reaches a minus 2.5 standard deviation. It's a really complex idea to get your head around. But the T-score, what the scanner produces, I should say, is a measurement, and that's in grams per centimetre squared. That's a density measurement. So that's the grams is the amount of mineral for the area. So the little bit of bone that we're measuring. We take that, grams per centimetre squared, and we plot it against a normal reference data. So this is comparing your bone mass to a whole bunch of other people who've had scans so that we can understand where your measurement sits. So the T-score is in relation to a young adult. So that's when we reach peak bone mass. Our bone mass grows and grows and grows as we grow, reaches a peak around 30, and then we start to lose bone mass in our 40s, 50s and 60s. So it's comparing to that peak bone mass around the age of 30. And standard deviation means where it sits against that mean of that peak bone mass on that reference data. So minus 2.5 against, compared to a young adult, is where we measure or where we diagnose osteoporosis. That's T-scores.
That's great. And I think, of course, as you've already sort of suggested, what we know is that there is this kind of close relationship, isn't there, Jill, between your bone density and your bone strength, what we call your risk of breaking a bone. So I guess it's the lower you are away from that kind of average range, that the greater your risk of breaking a bone. Is that a sort of fair way of putting it?
Yeah, that's absolutely right. So the closer you are to zero, the least risk. If it's a minus number and the further away you get from zero, the greater the risk.
Yes, and I think, and so as you say, osteoporosis is when you're -2 standard deviations. That's right, isn't it? Below, and that's your T-score of -2.5. That is. Perhaps you could talk a little bit about what that diagnosis of osteoporosis means, because people quite rightly are quite focused on that. They get the diagnosis and they want to understand exactly what that means for them. Perhaps you could talk a little bit more about that.
Well, the T-score and your bone mineral density measurement is just one of the factors that make up the overall picture of osteoporosis and your risk of breaking a bone. So it just adds to the whole picture of that.
So kind of like a risk factor for fracture, is that right? A bit like blood pressure and stroke, was that a useful description?
Exactly, it's just one of the risk factors. It doesn't mean to say if you have a T-score of -2.5, it doesn't mean to say you are going to break a bone. It just means you're more at risk of breaking a bone. If you have no other risk factors, your risk is limited to that.
Yeah, and that's something that I think people they find it quite hard to understand, but I think needs a bit of explanation. So a really useful tool, but it needs to be used with other factors because it's not a perfect measure. Would you say?
Absolutely. It's just one of the things that we look at to understand what people's bone health is and the risk of breaking a bone.
And perhaps you could say a quick word about the term osteopenia, because again, there's a lot of people get confused about that. Is it a disease? Is it a condition as such? And what does it mean for them?
Yeah. So osteopenia isn't a medical diagnosis. It's a term we use to describe a bone density that is below the normal range, or it's within the normal range, but it's slightly below. It's when somebody has lost some bone mass, and we all lose bone mass after the age of 40. And it's just a term that we use to describe the state of the bones when there has been some bone loss.
And I think that's helpful to understand too. So we've talked quite a bit here about sort of, I guess, accuracy really, because people say, is this accurate? Is it useful? And what you said is absolutely it is, but it does have limitations, and we just need to understand all that. Because sometimes we get asked, how can I have a higher fracture risk with osteopenia? But your point being is, look at the whole situation, and all the factors that research have shown tell us something about bone strength. We've had a question about screening. I think this again is a common question. So if it's so useful, why doesn't everyone, or certainly every woman, say, have a scan at the menopause or when they reach 50? Could you perhaps just say a little bit about whether or not it's whether it's a screening tool as such?
Well, it is not a screening tool, and there are several reasons for that. The first one is we know lots about the risk factors for osteoporosis and fragility fracture, and none of them involve, or recognising those risks or understanding those risks don't involve a dose of X-ray. A DEXA scan involves a dose of X-ray, so we wouldn't automatically scan everybody because we already know who is likely to be at risk. So we do that bit first, the risk assessments bit first, and that helps us decide who would benefit the most from having a dose of X-ray, to have a DEXA scan to go on and diagnose osteoporosis or inform the fracture risk a bit further or monitor changes and things.
Okay, and lots of questions here. I'm going to try and squeeze them all in. People do ask how common it is to have bone density in the osteoporosis range. So, because we know that does become certainly more normal in older age, even though that still matters because it still means your bones aren't strong. So, how common is it really in your 50s, 60s, 70s perhaps to have osteoporosis on a scan?
Okay, so I talked a little bit about the reference data that we use, and we can use that to understand what the normal distribution of those bone density levels of having normal osteopenic or osteoporotic bone. So around 50 years old, this is looking at the female reference database. At 50 years old, about 25% of women will have a lower bone mass in the osteopenic range. We wouldn't expect them to have anything in the osteoporotic range. At 60 years old, about 90% of women will have a low bone mass in that osteopenic range. And that's because for most women, the menopause happens between the ages of 50 and 60. So it falls in this year. And we experience about a 2% per year bone loss during those menopausal years compared to men and postmenopausal women who lose about 1% a year. So that explains why it suddenly jumps from 25% to 90% having a bone density in that osteopenic range. And by the time we get to 70, because of that natural age-related bone loss, 100% of women age 70 will have bone mass in that osteopenic range, but not into osteoporosis. So it's a little bit later. At about 80 years, then about 50% will have a low bone mass in the osteopenic range, and about 50% will have osteoporosis.
Right, that's really helpful. So what we're saying is pretty much when you're getting towards your 80s, half of us will be in the osteoporosis range. And then, of course, as we say, we know that getting older in itself has something to do with bone strength and bone quality. Perhaps a quick word there about bone quality, because we won't go into too much detail, but going back to what you said about the bone density not being the perfect measure, we know there are changes in the sort of structure inside bone, the quality of the bone, and that is something we can't absolutely see from the DEXA scan. Is that the case?
Well, that's largely right. Yes, we can't understand what the quality looks like from a DEXA scan. There is some technology built into DEXA called trabecular bone score.
I was going to ask that. That's really helpful. Yeah. So just for everyone listening, this is something called trabecular bone score. We had a question. How useful is that, and will you get that measurement, and should you?
Yeah. So you probably won't get that measurement because we still don't yet understand how useful that is in clinical practice for everybody in the population that we're scanning with DEXA. But what that does, it looks at the distribution of the internal mesh in the bone, and looks at the pattern that makes. It ascribes a score to that. Right. And we don't think it adds an awful lot more to fracture risk assessment, but it might add something about the quality of bone. But we're still waiting to hear what all the evidence and what the science says about that. But it's available on many scanners. It can be put into the fracture risk assessment tools, but we haven't yet got the definitive guideline on how that can be used in clinical practice.
So it's a kind of watch and wait this and see what happens, and we'll keep you up to date as we find out more. So not essential yet. Now another question, a little bit of a technical one again, is sometimes people find that they're seeing or hearing they've got a very low bone density in their spine, but they haven't got a low bone density in their hip. Now, there's all sorts of discussion about how this is used when fracture risk is being determined. But from your point of view, in terms of DEXA scanning, how can you have low bone density in one place and not another, and what does that mean for somebody?
Well, that's a really, really good question, really interesting question. So the bone density is distributed, or is affected differently in different places, and it's different in everybody. Just as our faces are different, our internal mechanisms, our metabolism is different. So sometimes you're absolutely right, the spine will have a lower bone density than the hip. Sometimes it's the other way around. And the important thing is that the person reading the scan can understand the impact of that on fracture risk assessment, because we use the hip measurement in fracture risk assessment. So if the spine density is much lower than the hip, it doesn't take that into account. So it's important that the healthcare professional understands that and can adjust for that or allow for that, so that we know that the fracture risk assessment is much more accurate if we can take that into account. And the spine, of course, is likely, as we get older, it is more susceptible to degenerative changes. That's wear and tear, and that can confound the DEXA measurements. So having a really well-trained, highly skilled expert understanding, taking the scans, reading the scans, is really, really important to get the best from them.
And I think, as you're saying, it needs some sort of clinical judgment too, doesn't it? So whoever's helping you, treating you, and making decisions will want to kind of look at all these things and come to the best decision. And it might mean that the tools don't provide the answers, and they have to make a judgment outside of what the FRAX or the DEXA says, which is a little confusing, I think, for people, but is often the case.
It is confusing, and you're absolutely right. Clinical judgment is really important for everybody. Because everybody is individual, it has to be considered individually. So it's really important for that.
And I think another question's coming about, will it show if my treatment is working, my drug treatment? And I think you've said that, yes, it can help with that, although again, sometimes people are disappointed, aren't they, that they can't have very, very regular scans. So perhaps talk a little bit about changes in scan results, how long you need to leave it, and whether one can use that for understanding if a treatment's working.
Yeah, Absolutely. So yeah, you're right. Some people do feel disappointed that they can't have a scan every year to understand what's happening with their treatment. And when they do have a scan, it might not have changed, and then they're disappointed with that. So there are two things going on here. First one is the frequency, how often we can measure your bone mass and make meaningful understandings of what has changed. So because we're using an X-ray technique, there are some random elements that come into that. It's all to do with how the X-rays interact in the body, and how that randomness is what we call precision error. And we need to be able to wait for a certain amount of time for the bone mass to catch up with whatever is happening, for the bone mass to change with treatment, or for the bone loss not to happen, for us to be able to measure that. So it needs to change by about 4.5% for us to say that it's a true and real change. And that's because we could just be measuring precision error if we do that any sooner than that. And then there are the clinical elements of that. So some of the common treatments, we don't really need to measure you every year or every other year, but at a certain point in time when it's really beneficial to understand whether it's time for a treatment holiday, whether it's time to change a treatment, and that will vary depending on the treatment people are on. So just a word about when people are disappointed that their bone mass hasn't changed. Some of the treatments, of course, they're designed to prevent bone loss. So we're not expecting necessarily to see the bone mass increase, but if the bone mass has stayed stable on that treatment, that's actually a really good success story, because it means you haven't lost that bone mass that we expect with normal aging.
And this question about you need to change by quite a number of percent for it to be what's called significant. This is something where your skilled interpreter, the radiographer, whoever's doing your scan, will be making all those judgments and making sure that a good interpretation is given to whoever's helping you with a drug treatment decision. Is that a fair comment?
That's absolutely right. So the first thing we will consider is it a real change? Is it a statistically significant change? Is it a real change? And that's where that 4.5% comes in. And then we'll look at how much percentage over the years between the first scan and the second scan it is, and whether that is clinically significant. And that's the same for whether you're on treatment or whether we're monitoring bone loss in other circumstances. We will then make a judgment based on, is this normal or is this not normal? And that puts the difference between whether it's clinically significant or not.
That's great. Carol's asking about comparing scans from different scanners. I know this is all a bit complicated, but it's really about why can't I have a scan in one place and then go and have one in another? And I know you've said before that there'll be difference between different makes of machines, but apart from that, what is the issue really here?
So the issue is that there is an issue around different manufacturers. They generate their X-rays, the two different energies of X-rays, in different ways, so they're not comparable. They have different databases, reference databases, that they're not comparable for those reasons. But on a day-to-day basis, if scanner A is in one city and scanner B is in the other, but they're the same manufacturer, they still will have inherent differences. Their calibration will be at different levels. So unless we really understand the differences between those calibrations, we can't compare two scans on those two different scanners.
And I think it's helping people to understand that doesn't mean it's a waste of time and they're not accurate and reliable, but there are going to be small changes. So one could, in theory, sort of slip between osteopenia and osteoporosis just because of that. But it's about seeing it all on a continuum and having that overview, isn't it, really?
Yeah, absolutely right. Where we are setting a threshold, and we'll take the minus 2.5, if I was to scan somebody 3 times in a row without changing anything, and it was at minus 2.5, it might be minus 2.51 or minus 2.49. And, in that time, it's a small percentage change, but because it sits around a threshold, it can slip either way. But the scans are reliable and accurate. We know a lot about DEXA, and we know that they're really proven to predict fracture risk, target treatment, monitor response therapy, and all those things that we talk about. We know that they are really reliable.
Quick question that's just come in. I have so many, so I'm going to rush a bit, but what about if I can't lie down flat on my scanner? I mean, is there a problem if you're somebody who is disabled, perhaps because of spinal fractures or other conditions? Is that going to make it a problem?
So let me start by saying why we scan the spine the hip, and we can scan the forearm. So the spine and the hip, we scan those places because there's lots of the type of bone that's affected by osteoporosis, and that's the mesh type bone that's inside the shell of the bone. Lots of type of bone that is really reliable. We can scan it over and over again and reproduce that positioning and that scan time and time again. So that's why we start there. But if somebody can't lie flat, what that means is that we're not going to get a reliable measurement of the spine because of the way X-rays work and the way geometry works and the shape of the beam of the X-rays and things like that. We will always try and help patients to be as comfortable as possible. It's a collaboration between us and our patient to get these measurements. It's not something we're doing to you, it's something we're doing together. And if people can't do that, then we will look for other ways of doing it, which might mean we scan a forearm instead of the spine or instead of the hip.
So there might be other sites, and that's something to discuss and not feel too anxious if it's a problem for you.
Absolutely.
Great.
And I think it's worth a try. You know, it's always worth a first
with some
attempt
help
and work with a radiographer to help. Yeah.
Great. All right, on we go. Can a DEXA scan show if you've had a spinal fracture? So this is often really important. If people have got pain, they're looking to understand have they had a fracture. What can the DEXA scan show or not show?
Okay, so the DEXA scanner is it's a measurement tool. So it's a bit like a ruler. It will tell you how long something is, but it can't tell you what colour it is. So that we do get images from the DEXA scanner, but they're very poor quality, very low resolution, and don't give us an awful lot of detail. But we can see the area of the vertebral bodies. Vertebral bodies are big chunk, kind of building blocks in our spine, if you like. So we can see if they've been squished down. We can see if there's lots of degenerative change there, but it's not definitive. We can't say categorically this is a fracture. So sometimes there is another type of scan we can do with a DEXA scanner called a lateral vertebral assessment or a vertebral fracture assessment, which is a scan of the spine sideways, that we can see the shape of the vertebral body in its entirety, and we can measure that and see if it's a fracture or not.
Oh, lots of good stuff there, Jill, but it's complicated, isn't it? So something called a VFA might be attached to the DEXA scanner and might help with identifying, but that isn't going to be something which your GP refers you for. It would be done alongside your DEXA scan. So I think what we're saying is, and I'm just checking this with you, Jill, that the spinal X-ray is still the kind of gold standard for finding out if you've got a spinal fracture. Is that correct?
In absolute general terms, yes. Yes,
Yeah.
There are some centres that might have a slightly different pathway, but that will be very much down to a local pathway.
Okay, that's great. Right, we have very little time left, but we have got another few questions come through, and I know they're important to some of you, and these really are about other types of scanners. So can we just whip through and try and cover a few of these, because I know people want answers. An MRI scan, what's that used for?
So MRI scanners are really good at looking at soft tissue. We can't actually see a bone on the MRI scan because the thing that we're looking for is hydrogen in MRI scanners, and that's so tightly bound in bone mineral we don't actually see it. What we see is a gap where the bone is. What we can see on MRI, and it's what is really useful in osteoporosis, sometimes in some patients, if there's a vertebral fracture, it will help us identify whether it's a new vertebral fracture or an old vertebral fracture. But that's not for everybody.
No.
It's just a small group of patients that might benefit from special treatment for that.
Lovely. CT scanning, so computerized tomography, what's that all about? Because we've heard that can help you to understand something about about bone strength.
Yeah, so CT stands for computerized tomography. It's using X-rays again and a detector. What it does like slices of a cucumber type thing of whatever body part we're looking at. So there are two types of CT that we can use in osteoporosis. There's a peripheral CT scanner, which can measure the bone mass in the wrist. Those are pretty portable. They're applicable to the World Health Organization, but we can't monitor changes really well with that because it takes so long for bone to change in the wrist for us to really be able to monitor changes. The other type is where we can scan the spine in the CT scanner and make measurements of the bone density, and it's actually really reliable, really accurate, really good measurement, but the X-ray dose is that much greater. We wouldn't use it as a screening tool. We wouldn't use it in the same way we do DEXA because we have something that does an equally good job for a much lower X-ray dose, which is the DEXA scanner. So it tends to be used in settings for research at the moment, and there might be pathways in the future where we're using that to identify patients who could be at risk of osteoporosis as an opportunistic kind of way of searching for people.
That's really helpful. So I think we've already learned a lot about a number of different methods. We've learned about using X-ray with DEXA low dose, about ordinary X-rays as we understand them, CT scanning, MRI scanning. Now there's one other method and technology which we get quite a lot of questions about, and that's ultrasound, and we're all understanding that ultrasound also measures things, and we see it in pregnancy and so on. Now for many years ultrasound has also been used, hasn't it, particularly in research to try and understand strength of bone, and does tell us something. And more recently there's a new type of ultrasound called REMS, and I think there's quite a lot of interest in this because there's a feeling that it doesn't have radiation and it's portable, and that it may, as these other methods, tell us something else about bone strength. So quite a few questions. I've got a list of people here who I've picked up: Elaine, Alex, Anne, Margaret, Elizabeth. They've all asked, why don't we use REMS? It's less radiation, more accurate, and should I be asking for one if I can't get a DEXA? So there, I wondered if you could update us and tell us first quickly what REMS is. It's a type of ultrasound, am I right there?
Yeah. So should I just go to ultrasound first, because then
Sure.
I can talk about REMS after that. So firstly, most ultrasound-only devices for bone measurement measure the heel bone. And because they use the heel, these measurements can't be interpreted with World Health Organization. So that means we can't use that in the same way as a diagnosis. And most people who have these heel scans, with ultrasound heel scans, will probably have to go on to have a DEXA. If they have a low measurement on the heel scan, they probably have to go on to have a DEXA to have a formal diagnosis to be able to access treatment. And also the treatment thresholds and fracture risk assessment isn't as well validated in that tool. So REMS technology uses ultrasound, but in conjunction with radio waves to make measurements of the bones. The scanners are really very new in terms of medical technology and are still being evaluated by researchers to understand how we can make best use of them to benefit patients. But it does look like a really promising as a technology to assess bone mass. But at the moment there isn't a lot of evidence, or there's not enough evidence for us to be certain that it's the best technique for routine clinical practice. So what we do know, there's no X-rays, so they are safe in terms of radiation dose. We also know that they're very similar in accuracy to DEXA scanners, DEXA scan measurements. They are smaller and more portable, in a sense they can be moved around on a trolley from room to room, but they can't be put in the boot of my car, and I can't go down to a clinic to scan a whole bunch of people in a clinic. So they are portable from that. What we don't know is how reliable they are in terms of being able to monitor changes in bone mass, and that's a really important part of measuring bone mass, is to be able to understand if treatments work, when to intervene. Those are the reasons we talked about earlier. We don't know whether they can be used to support fracture risk assessments across all patient groups. Most of the studies have been done in postmenopausal women, so we don't know if it's applicable to men or premenopausal women, so there's some more research there. And also, because REMS isn't regulated in the same way as X-ray DEXA is, it's not regulated by the CQC in that way, we can't be sure how the service is quality assured, we can't be sure who is carrying out the scan, what training they've had, or how reliable the results are because of that. What we do have is a lot of data about DEXA, and we can be reassured that with the weight of evidence behind that, it's a reliable method of measuring bone mass for diagnosis and informing fracture risk prediction, as well as those other things. So at the moment, DEXA stays as the gold standard. We know how reliable it is, and REMS is really promising, and it's really exciting to see this new technology and see how it's being evaluated. And who knows, in a year or two we might be having a whole different conversation.
So again, it's really watch this space. And I guess, is it fair to say people can go ahead and have these kind of technologies, try them, use them, but what we can't say is really exactly how accurate or reliable or useful they are in that sense. And it's unlikely that the healthcare professional looking after you will be familiar and able to sort of apply that in making decisions about drug treatments and so on. Is that a fair comment, would you say?
I think that is absolutely fair, and you know, if you are going to go and have a REMS scan, be absolutely certain that you've researched what it is you're getting and how they're quality assuring their service.
Okay, well, I think that's sort of future possibilities. It's a good place to stop. I'm afraid we're going to have to wrap things up, and it's been really great, as always, talking to you, Jill. I mean, and lots of really useful and helpful questions coming in. And I'm sorry if we haven't answered your question, but we're pointing you after this to many of our resources, and you're very welcome to call our helpline if you want to talk to our specialist nurses. This is one of a series of Bone Matters webinars and Facebook Lives, so watch out for the next one. We'll be talking about drug treatments in May, and we hope you'll be able to join us. So thank you very much, Jill, and thank you to everyone who's listening, and we'll see you again soon.